Well, I know there's a lot to cover, and a lot of people have um, questions that they want to get to at the end. So why don't we go ahead and get started? And then if people join in, we'll catch them up to speed. So, Bill, did you have any housekeeping issues
Well,
you
I did. I gotta hit the record button.
want to
Okay.
start with? Okay.
Resume recording. Okay, I am gonna put stuff in the thing. Let's see. Copy this. All right. Put it right in the chat so everybody can see it. It was told to me, keep your mics off. So put all your questions in this chat box. Questions will be answered by the end of the presentation. If we can't get to all of the questions by the end of the presentation, we will email out answers to everybody. Okay? I'm going to turn it over to Vicki to do the introduction to the doc, and we'll go from there.
Well, hello everyone. Thank you for joining us tonight. I'm Vicki Platt, the current president of the AHC Foundation. I have a 24-year-old daughter, Emma, and we live outside of Chicago. And I also wanted to just thank Bill Gerber, who's on the board, for doing all of our tech support and keeping us recording and on track. And I also want to thank Beto and Sharon for helping to coordinate our webinar educational series this year. So we have a lot more coming your way, so stay tuned for announcements on future programming. But tonight I would like to introduce Dr. Andrew Landstrom from CHOP, which is the Children's Hospital of Philadelphia. And he was formerly at Duke, where he was a co-author on several really important AHC cardiac papers. And he's been a frequent guest speaker. He is on the AHC Foundation Medical Advisory Board and just an all-around great person. Dr. Landstrom transitioned from North Carolina up to Philadelphia, where he is leading the Clinic of Inheritable Arrhythmias, which will specialize in clinical care of patients with genetic arrhythmia syndromes. And they will provide world-class care to all patients, as well as continuing their understanding of AHC and ATP 183 variants. So it is my great honor to turn the presentation over to Dr. Landstrom. He'll continue with another introduction and have a presentation for you this evening.
Well, thank you, Vicki, and thank you to the AHC Foundation for the chance to be here and to engage with all of you. I hope you all are warmer than I am right now, wherever you are. I have a few slides I'd like to share, but before I do that, I'd like to introduce you all to Miss Terrell Schmidt, who is the genetic counselor that's been with me at Duke and has come with me up to CHOP. And she has a few slides to share because we work, her and I, as a team. And so we figured we would approach this presentation for you all as a team. And undoubtedly, as Terrell and I present, questions will arise. Just throw them into the chat, and we'll get to all of them at the end. Terrell.
Great, thank you so much. I will share my screen. And all right, do the slides look good?
Perfect.
Great, thank you. So hello, everyone. Thank you for having us. I'm Tara Schmidt, and I'm, of course, joined by Dr. Landstrom. We're here to talk to you today about alternating hemiplegia of childhood and the role that genetics play in understanding cardiac risk in this condition. Like Dr. Landstrom mentioned, I'll do a brief overview about genetic counseling and how it can be an important part of your care. And then I'll turn it over to Dr. Landstrom, who will go into more depth about the genetics of AHC, the associated cardiac manifestations, and screening recommendations. But before we dive further, I wanted to take a moment just to introduce us again. We all know Dr. Landstrom, the esteemed cardiologist. I am a pediatric cardiology genetic counselor, and I'll get into more of what that means in a little bit. But importantly, I wanted to highlight that Dr. Landstrom and I work closely together as a clinical team. So we see patients jointly and collaborate to provide comprehensive care for patients and families. So I'd like to start by talking about what genetic counseling is. Because genetics play such an important role in AHC, you may meet with a genetic counselor, such as myself, at some point in your medical journey. Genetic counselors are specialized healthcare providers trained in both medical genetics and counseling. Our role is to help individuals and families understand the genetic aspects of a condition and what it means for them. So, our role includes reviewing family history to assess for inherited risks, coordinating genetic testing when appropriate, interpreting genetic variants that are identified on a genetic test, and helping you understand your genetic test results and what those results mean for your health and your family. But above all, we provide support throughout this whole process. So the genetic testing and the diagnostic journey can feel overwhelming at times for families, especially since there can be uncertainty and complex information. So a major part of my role as a genetic counselor is to provide support, to answer your questions, talk through concerns, and help you make informed decisions that feel right for your family. And in terms of training, genetic counselors are not physicians, but we do complete a specialized master's degree in genetic counseling, and we are also board certified professionals. So now that you know what a genetic counselor does, let's look more closely at why genetics is so important in AHC, particularly when it comes to cardiac risk. As many of you may already know, AHC can be caused by changes or variants in genes, most commonly in a gene called ATP1A3. This gene plays an important role in regulating electrical activity in both the brain and the heart. We now know that certain ATP1A3 variants have been associated with an abnormal heart rhythm or arrhythmia. That said, we still do not fully understand the degree of arrhythmia risk across all individuals with AHC or ATP1A3 related disease. So, because of this uncertainty, current recommendations are to pursue cardiac screening for all individuals with either an ATP1A3 variant, regardless of symptoms, or a clinical diagnosis of AHC, regardless of whether a genetic variant has been identified. The goal is not to cause alarm, but to be proactive as research is still developing. And this is one of the many reasons why you may meet with a genetic counselor when you come to your cardiology appointment. So what can you expect from this visit? This visit could either be in person or via telehealth. Sometimes the genetic counseling visit happens alongside the physician appointment, and sometimes it can be scheduled at a separate time. The evaluation may include reviewing any genetic test results that are available for either yourself, your child, or any family members. We will discuss what we know about your specific genetic variant and any known information about arrhythmia risk. I also take a detailed family history and create what's called a pedigree, which looks something like this. If you can see my cursor, this family tree right here. And this helps us assess whether there may be inherited risks for other family members and anything else that we need to know about family history. And we may talk through the genetic testing process if it's recommended for your family. So this includes what testing may be appropriate, costs and insurance coverage, different types of results, and other important things to consider when making the decision to do testing. And this is typically done through a simple cheek swab, which we then send off to the laboratory for sequencing. So to help you prepare for your visit, I've included a checklist here of helpful items to bring to your appointment, which include any prior genetic testing records, information about family members' cardiac histories, any prior cardiology records, and of course, any questions that you have. The goals of this visit are to help you understand your genetic test results and inherited risks, identify other family members who may benefit from testing or from screening, and most importantly, to provide support and answer your questions along the way. So thank you for letting me tell you about genetic counseling and for my brief presentation, and I'll pass things off to Dr. Landstrom.
Thank you, Terralyn. Can you all see my slides okay? They're looking good?
Perfect.
Okay, wonderful. Well, good evening and good afternoon, everybody. It really is a pleasure to get the chance to talk to you a bit tonight about why ATP1A3 variants and AHC have an association with the heart. And I'd like to share with you a little bit about how it is that we stumbled upon this. And I want to paint the picture for what we can do about it, the research areas that we're currently pursuing, and what are the considerations for you all as you seek clinical care for your child with AHC. So as this audience very well knows, AHC comes with a constellation of signs and symptoms. Chief among them are abnormal eye movements and seizure-like activity, dystonia or stiffening, hemiplegia, which just means weakness or paralysis of maybe an arm or a leg or one side of the body or maybe all of the extremities. Um, and for a long time, it was known that there is this rare thing called sudden unexplained death in AHC. It wasn't very common, but when it happened, it was really quite scary. And oftentimes, when sudden unexplained death happens in individuals who have a history of seizures, it gets labeled something very specific, SUDEP, or sudden unexplained death in epilepsy. And so for many years, this was sort of left unexplained and was felt that maybe the seizures had something to do with it, but really the cause was unknown. Well, many years ago, I was on call and I was asked to come down to see a 4-year-old girl who was having an arrhythmia in our ICU. And this was the arrhythmia that she was having up top. And this is an arrhythmia called ventricular fibrillation. Can you all see my cursor if I move it around? So this is an abnormal heart rhythm where the heart is not beating normally. And these big spikes here are us trying to shock the heart to break this rhythm. And as an arrhythmia specialist, we're specifically trained in kids with arrhythmias, and we were unable to break this arrhythmia. And ultimately, she died that night. Looking back on her tracings that we had on her heart because she was in our ICU, her heart tracings were abnormal. So these are our normal heartbeats, but they're a little bit short, meaning the heart, these complexes are narrower than they should be. Excuse me. And we'll get to that, what that means in just a little bit. And then she had these long pauses where her heart actually didn't beat for long periods of time. We'll get back to that. But at the time, with this 4-year-old little girl and this tragic death, we were really left wondering what just happened. And oftentimes, when you have children with these arrhythmias, the answer is actually genetics. That's why you just heard from Ms. Schmidt, because our suspicion is very high for something in the DNA that might explain this. And so we sent the normal genes that we would normally send for gene testing for arrhythmias in kids, and they came back negative. Well, at the time, we were just starting our research lab. And so in addition to being a doctor, a physician, I'm a scientist. And whereas medicine here would kind of be at a crossroads and we don't know what the heck just happened, science really can push the boundaries a bit and start to ask, well, what are we missing? And so we decided to take her DNA with the consent of her parents and sequence lots and lots of genes to see what is it that we're missing. And we actually found a mutation in a gene that by now is familiar to all of you, ATP1A3. And specifically, we found the ATP1A3 D801N missense variant. And this is that pedigree that Ms. Schmidt just talked about. This is that little girl down here. And she's got that variant and had this very terrible arrhythmia. And everybody else in the family didn't have the variant, and everybody else in the family was healthy. And so from this one case, from this one tragic death, we set about trying to figure out how it is that this gene actually plays a role in the heart. And when we started, the only thing that was known about ATP1A3 was that it plays a role in the brain. It plays a role in how the neurons stabilize themselves electrically. And when it's mutated, like in AHC, the neurons don't fire like they normally do all the time. But the role in the heart was completely unknown. And this little girl would strongly suggest that there is something to be said for a role of this protein in the heart itself. And so we set about trying to figure that out. ATP1A3 is the gene that encodes an enzyme, a protein called the sodium potassium ATPase. And what this ATPase does, at least in theory, is it rebalances the salts in the cell, specifically sodium and potassium. so that with every heartbeat, these ions move across the membrane going in and out of the cell. And this ATPase is responsible for moving them back so that the heart can beat again. And so we set about trying to figure out what's going on with the heart. Why does D801N cause this condition? And so being a cardiologist and arrhythmia specialist, we turned to the best electrical test of the heart that we can do, which is called the electrocardiogram. And you've probably seen this if you've gone to a cardiologist's office. This is a 12-lead electrocardiogram. And the squiggles are the electricity moving in and out of the heart. And all the different letters and numbers up top are just different views of the same heartbeat. And we use this as a way of learning about the electricity of the heart. And so the first question was, well, we had those suggestions from that 4-year-old little girl that maybe the electricity in her heart wasn't normal. So can we look at the ECGs of children who are normal? Some of those who have a diagnosis of AHC, and some of them who have mutations in the gene ATP1A3. And maybe we'll start there and see if we can figure out what's going on. Well, this is a healthy child up top and their ECG. And down below, it might be a little bit hard to see on the screen because the colors are a little bit different, is a child with D801N. So up top, you can see this big spiky thing and then this lumpy thing here at the back end. And this is the heart beating electrically and resetting electrically. And this big spiky thing is the heart squeeze, and this is the electrical relaxation that happens. And the time between this spiky thing and this lumpy thing is called the QT interval. And it's just named after the actual waves on the ECG, the Q and the T. The x-axis, if this were a graph, here is time, meaning the longer the QT interval, the longer the time it takes for the heart to electrically reset. And you can see here in the sort of black bar, that's the QT interval in a healthy heart. This is the QT interval in a D801N individual. It's much shorter, it's much narrower, meaning the heart is resetting faster than it normally should. That's what this short, and that's manifest as a short QT interval here. So a quick primer in cardiac electrophysiology, this QT interval is the amount of time it takes for the heart to electrically reset. And this can change depending on heart rate. So if your heart rate goes really, really fast, this has to shorten so that your heart can beat again. If your heart slows down, the QT prolongs so that you can have a slow heart rate. And so oftentimes what we do is we transform this QT measurement, which is time, to a QTC. We correct it for heart rate. That way, if you come in and your heart rate's a little bit fast that day, we don't think your QT is off. We correct it. We calculate the QTC. Come in the next day, your heart rate's a little bit lower. The QTC should still be the same, even if the QT changes. And once you've calculated the QTC, we ask, is it normal or not? And as you can tell from this graph here on the right, a normal QTC ranges from 370 milliseconds to 460 milliseconds. If it's higher than that, if it's greater than 460 milliseconds, it gets to be prolonged. And the higher that number, the more prolonged it is. If it's less than 370 milliseconds, it gets to be short, too short. And the shorter that number, the lower that number, the shorter the QTC, the more abnormal it is. And so we sort of throw around 350 milliseconds as being sort of the threshold between an abnormally short and a borderline QTC. And so if your QTC is less than 350, we think of it as being too short. So this was the first study that we did, circa 2021, which feels like many, many years ago. But this was looking just at the patients who at the time we had seen at Duke with Dr. Mohammed Makati, who might be a familiar name to some. He's a pediatric neurologist that specializes in AHC that we've been working with ever since. And at the time, we had seen 61 patients with AHC. And we asked, well, if we look at the ECG, what's their QTC? Hypothesizing it would be short in individuals with that D801N mutation. And you can see here, these are graphs looking at the QTC of individuals with typical criteria for AHC and atypical criteria for AHC. And regardless of how we broke that group down, there was no real difference in QTC. It just seemed as a group to be normal. If you had a mutation in the gene ATP1A3, your QTC was a little bit shorter than if you didn't have a mutation in the gene ATP1A3. And specifically, that was driven by individuals who have the D801N mutation. You can see here, if you have that D801N mutation, the average QTC was well below that threshold of 350 milliseconds, meaning not all, but many children who had the D801 mutation had a pathologically short QT interval. And you can see that here. Here's that normal QTC, the normal QT interval, and here's that QT interval. It's too short. You can see that T wave really kind of abuts that QRS. In addition, we had two individuals who had that life-threatening arrhythmia. One was that little girl I talked to you about on the first slide. The other was a child who was at Duke, was waking up from anesthesia and had a very similar VF arrest. Luckily, we were able to intervene and save this child, but we had two individuals who had a pretty scary arrhythmia, and they both had the D801N mutation. So this was some evidence in a somewhat small cohort of a very rare disease that perhaps we were on to the right thing. We then asked, well, in science, the best thing to do is to do an experiment in multiple different places under multiple different environments. And if it's true, it's going to be true everywhere. And so we asked them, well, what if we brought other groups together? And there are institutions around the world that have cared for at least some patients with ATP1A3 variants and some patients with AHC. And we worked together to say, well, maybe we could look at your cases and we can learn from your cases. And so we recruited roughly a dozen other institutions from different countries around the world and asked them to send us, please, your ATP1A3 cases and your cases with AHC. And does this replicate? Do we see this finding worldwide? And the answer is yes. And so these are examples of three of the most common mutations in ATP1A3. This is that D801N, the E815K, the G947R, and then we had a handful of mutations that are considered loss of function mutations, like the gene got deleted, or there's an intron exon splice problem, which we think kind of causes the gene to be lost. Or there are individuals with AHC who have no mutation. And as you can see, the QT intervals for the D801N cases continue to be very, very short, whereas by and large for the other mutations, it was normal. And that's quantified down here in these graphs. So panel B, the y-axis is the QTC. And if you're genotype positive, meaning we've got some sort of mutation, versus genotype negative, meaning we don't have any mutations, the QTCs are more or less normal. And then if you go mutation by mutation, what you find is that the D801N mutation, on average, those individuals have much shorter QTCs. Not all, but many. And for the different other mutations, the E015K, the G947R, or the other types of variants, many, but not all, have normal QTCs. And if you ask, well, what's the percent? That an individual will have a abnormal QTC. We have that here in D and E. So the y-axis is the number of individuals percent-wise with a particular mutation who have a QTC less than 370 or a QTC less than 350. And here we calculated what's called a penetrance of about 66% and of about 35%. Meaning, if you have the D801N mutation, you're about 2/3 likely to have a borderline short QTC and about 1/3 likely to have a pathologically short QTC. The other mutations, you're more likely to be normal, but there's still this sort of underlying possibility that your QTC still might be short. For example, roughly 10% of the patients with the E815K mutation will still have a short QTC, meaning it's not all genetics, and we don't understand this entirely, but we think that there does tend to be a predisposition to arrhythmias if you've got this short QTC, and that genetics plays a role in helping to identify who's at risk. Now, luckily, the number of individuals we found worldwide who had a serious cardiac event was low, but all of them were individuals who hosted that D801N mutation. And so these are just bar graphs looking at the number of individuals who had some sort of a nasty cardiac arrhythmia. Here, 10%, roughly 4 out of the 35 patients with a D801 mutation worldwide had a scary arrhythmia, whereas the other mutations did not. And 2 of them occurred during anesthesia, during periods of heart rate slowing. And so we didn't really know what that was or why that was in the past, but we did notice this sort of association that the children seemed to be fine until they were given those medicines to go off to sleep. Remember that child who was in the ICU for seizures and getting medicines for those seizures, or the child who was waking up from anesthesia from an MRI? We thought, well, perhaps there's something with sedation, anesthesia, and heart rate slowing that's predisposing them to having these arrhythmias in the setting of a short QT interval. And we sort of tried to calculate the event rate here. And so we think there's this 0.6% chance per cardiac event per 100 years of something happening, which means it's not zero, but it's rare. And there's more chance of this happening in the setting of anesthesia. Now, this is an area of active research for us. We really want to try to understand what are the risk factors that are predisposing individuals to having these arrhythmias, and we do think the heart rate is one of them. And to kind of illustrate this, these are 2 graphs that look at the relationship between QT interval and QTc and heart rate. So as I mentioned previously, in a normal heart, as heart rate goes up, the QT interval goes down. And that's because, if your heart's beating faster and faster, you need that QT interval to shrink so your heart can reset quickly. And then when your heart rate slows down, it prolongs. That's normal. That's physiologic. And if you know that and you correct for heart rate, that means the QTc, the corrected QT interval, kind of is always the same across lots of different heart rates. And so a normal QTc is always kind of flat. Well, what we have found is patients with specifically the D801N mutation, their QTc line is not flat. So in healthy individuals, it is. In individuals with other kinds of mutations, not the D801N, it tilts a little bit, but not a lot. And in individuals with other types of mutations, it tilts a little bit, but not a lot, meaning overall, the QT changes normally with heart rate and the QTc remains flat. But in individuals with the D801N, that line is tilted, meaning the slower their heart is, the less their QT interval prolongs normally. So relative to heart rate, that QTc gets shorter and shorter and shorter. And the shorter the QTc, the more arrhythmia risk there is. And so we think as the heart rate slows for these individuals, there is a bit more risk. And that risk goes up the slower the heart is. For a longer period of time, that risk is maintained. So sort of like an area under the curve. The slower the heart rate for the longer period of time, the more risk there is that develops for arrhythmias. Just to kind of illustrate this, these are sort of based on our model. Remember, QTc at 350 is too short. You can see that healthy individuals with a range of heart rates from 60 to 100 have a normal QTc. The D801N, if their heart rates speed up, it's kind of normal. But when their heart rates slow down, that's when you start to see that QTc shortening. Conversely, for other types of mutations as a group, that QTc doesn't really change with heart rate. In addition, we think there's another type of kind of rare cardiac rhythm problem that happens with patients with AHC, and that's the normal pacemaker of the heart can be abnormal in some patients with AHC. So specifically, we all have a pacemaker that lives normally in our heart, and that pacemaker speeds our heart up and slows our heart down. Speeds it up when we're running from a bear, slows it down when we've just had Thanksgiving dinner or we're falling asleep. And for patients with AHC, we know that pacemaker doesn't work as well and can speed the heart up inappropriately and slow the heart down inappropriately. We also think the brain has a lot of roles to play here in this sort of dysautonomia. But it can be really quite severe, meaning that some patients will require a pacemaker to be put in because their own pacemaker of their heart is so abnormal. And this just sort of quantifies that. It's not very common, but every now and then you'll have an individual as they get older with AHC who their pacemaker doesn't work well. And so we think there is this interplay between the pacemaker of the heart not working well, maybe perhaps slowing the heart abnormally, in individuals with kind of the right mutation, the D801N predominantly, with an already short QTC, and then we give them medicines to slow their heart down, and that sort of trifecta of things puts them at risk of arrhythmias. At least that's our hypothesis going forward. There's been a lot of rumors out there. Well, what about heart muscle disease, cardiomyopathy? What about heart failure in patients with ATP1A3? There was rumors in the literature that they're at risk of muscle disease and losing heart squeeze over time. And when we looked worldwide in the largest cohort, 148 individuals who had cardiac evaluations, we found none who had any evidence of that. So when you go get that echocardiogram, right, they're almost always normal. We've had 2 individuals who've had abnormal echoes for us out of the 148, and those were small things like mild dilation of the aortic root and an aortic valve that had 4 cusps instead of 3. But really, those are incidental findings. We have never seen heart failure. We've never seen heart muscle disease. It only looks like an electrical problem of the heart. And then what we're doing now in the research lab is we're actually trying to see if we can do something about this. And so what you're looking at is a video of heart cells that were made from a patient. We can take a few drops of a child's blood, turn those blood cells into that child's stem cells, and then guide those stem cells into becoming that child's heart cells. And we can grow those heart cells in a dish, and they beat. You're seeing evidence of it right here. And so that makes a wonderful model for us to be able to learn about this mutation. And without getting kind of too nerdy, because the science gets really, really deep, I'll just say that we have made these cardiac myocytes with the help of folks like Al George, who have used those same stem cells to make neurons. We've sort of used them to make heart cells. And we've created a couple of different lines that all have that D801N mutation in it. And after about 6 years of study, we've actually pinned down what we think is going wrong with the heart cell. And it gets a little bit wonky, but basically, in patients with the D801N mutation, remember that's a mutation in an ATPase, the sodium potassium ATPase. It can't do its job very well. And one of its jobs is to kick out sodium. If it can't do that well, sodium is allowed to build up inside the heart cell. That sodium buildup impairs another protein here called NCX, which is the sodium calcium exchanger. That protein relies on sodium being low in the cell. When sodium is high, it malfunctions and actually loads the cell also with calcium, another ion. And that loading of calcium, we think actually is the trigger for the arrhythmias, particularly when the heart rate gets very, very slow. In addition, we have actually shown that if we take a very specific small molecule that blocks the sodium calcium exchanger and that pathologic calcium influx it does, we can actually correct the arrhythmias and correct the QTC in heart cells in a dish in the lab. That is a long ways away from being able to deliver a therapy for a child, but I will say it's proof of concept that this actually can be changed molecularly and might be treated down the road. But again, I'll say that that's a long ways from here, but we think we're on a path towards trying to do something about this. So if this science hasn't scared you away, let me tell you a little bit about how we are a resource for families with AHC and ATP1A3 mutations. So as Vicky mentioned, we've recently moved from Duke to CHOP. And CHOP has allowed us to expand the care that we give to families just like yours. We have a Center for Heritable Arrhythmias, which is on the 12th floor of this building, the Berger Building. We're in the penthouse suite because cardiologists like to be in the penthouse suite. And so this is where our clinic is. And so if you decide to come see us, you'll have quite the view of Philadelphia from the 12th floor. And the idea behind this center is that we wanted to make sure that expertise was co-localized around families just like yours, ones with arrhythmias that are genetic. So people like Tara Lynn, experts in cardiovascular genetics, these are the individuals that we want to surround your child with so they get specialized care. If you see a doctor and they've never even heard of ATP1A3, even if they're a specialist, they're not a specialist who understands that rare disease that your child has. And we want to do this for children with AHC, ATP1A3, and other genetic arrhythmia conditions. Right across the way is our research building. And so this is actually where I'm sitting right now. This is the Colquette Translational Research Building. Our research lab is there, and actually you can see it from Berger. And so when you're seeing us in clinic, you can actually look across out those windows and make sure we're all working in the research lab next door. But this is where the scientists are who are studying this disease process, and the buildings are right next to each other. I'll also say that CHOP is investing in a broader cardiovascular institute to bring together other scientists to tackle the biggest questions in pediatric cardiac disease, which is part of the reason I'm here in Philadelphia, to be able to lead that effort, which is very, very exciting. And so this whole floor is going to be filled with cardiac researchers for kids, which I think is pretty darn awesome. So when you go see a cardiologist, they're going to be thinking about how to diagnose your child. And so I thought what I would do is I would share my approach to how we think about the clinical evaluation for children with AHC. So the way I view the evaluation of your children is we want to identify who's at risk of having an arrhythmia. We've isolated it down to that one question for kids with AHC and ATP180 mutations. And we think genotype, that D801N mutation, is one kind of risky sign that we can find. That's why you'll be seeing Ms. Schmidt to make sure we understand your child's genetics and we don't get that wrong. We also think having that short QTC, specifically less than 350, but the shorter, the more, the shorter it is, the more we worry. That's the other risk factor. And that's not genetic, that's what we call clinical phenotyping. That's part of your child's overall evaluation. And we can see that by ECG. So the goal is to identify those risk factors. To do that, we recommend a comprehensive cardiovascular evaluation by a specialist in pediatric electrophysiology. And one of the things you should watch out for is the cardiologist who doesn't hand measure the QT interval. So if you get an ECG, the machine that did your ECG will try to calculate your QT and your QTC. And those numbers will be at the top of your ECG if you look. Almost without exception, the machine is not designed to accurately calculate a short QT interval. And so it'll guess it wrong every time, and it'll look normal. We're actually trying to figure out now the percentage of patients with the D801N and a short QT where the machine read it normal and was missed by the cardiologist accordingly. So if you don't see them hand measure it, I wouldn't trust the machine. All right. All of those were hand measured QT intervals from our study. What you can do to help? Bring all of your cardiac records. So Ms. Schmidt said, bring your genetic testing records. I love it. Bring all of that, the whole gene test record. And then if you've been seen by any cardiologist, we want to know what they found. What I find less helpful is what the notes say, right? Because the cardiologist has their opinion. I really want to see the testing that was done and reevaluate your child's testing from the actual tests, not the notes themselves. So rather than, the cardiologist note, I really want to see that ECG, the squiggly lines, because I want to remeasure it by hand. If you had an echocardiogram, the report's helpful. I really want to see the images. All right. If you've had a cardiac MRI, I really want to see the images. So bring all those. For reasons Ms. Schmidt talked about, ask your family. Has anybody else in the family had any cardiac concerns? So that you can come prepared and we can get that information from you, because you'll be surprised how many times we pick up something else in the family, because that family has given us some great information. And the cardiac tests come in lots of different flavors and variety. In our clinic, you can imagine that we're going to do an ECG on your child. We're going to do what's called an ambulatory, meaning a walking around heart rhythm monitor called a Holter monitor. And that's to look for heart rate slowing that's abnormal. And then if it's the first time you're seeing us, we'll do an echocardiogram, just because we don't want to miss anything. And then we have a big evaluation. You can imagine that first visit takes a long time because we don't want to miss anything. And then once we've established your care, we follow about every year or every other year or so, depending on your risk and your comfort level and your ability to come to Philadelphia, especially during the winter. But we recommend, whether you follow with us or locally with a cardiologist, which is also fine, a once yearly ECG, Specifically also too, if you've had lots of medication changes to handle the other signs and symptoms of AHC, an ECG is always helpful. We recommend a once yearly heart rhythm monitor. And then certainly if there's any changes in symptoms, the biggest one would be fainting in your child or unexplained loss of consciousness. We'd want to know. Sometimes we follow those with event monitors so we know what the heart's doing during those events. How do we manage AHC? Well, unfortunately, we don't have any medications we can give your child that will normalize a QT interval. But we have identified through our research what we think the risk factors are. Heart rate slowing being chief among them, and anesthesia, particularly anesthesia that's designed to slow the heart, being chief among that. And so we recommend avoiding, when at all possible, those specific types of medications. Beta blockers, for example, are great for lots of different things. We use them to treat arrhythmias for other patients, but beta blockers can slow the heart, and so we recommend those are avoided when at all possible in patients that are higher risk. In terms of anesthesia, not all anesthesia is the same, but we recommend avoiding specific types of anesthesia that is purposefully designed to slow the heart, which if you're an anesthesiologist, you want hearts to be slow, right? But not in kids with AHC. And so one of the medications we recommend avoiding is one called dexmedetomidine, which is an anesthetic that normally you would use in most cardiac patients, but for our patients, because it slows the heart, we recommend avoiding that. If your child has to undergo sedation for any reason, we recommend that's done in a hospital setting, meaning you don't want someone to sedate your child without having the ability to watch their heart rhythm, to look for heart slowing, and if an arrhythmia occurs, to act quickly. The child who had that arrhythmia that we were able to resuscitate, anesthesia was there very quickly, and we were able to save that child. So you don't want to have, sedation happen in a non-hospitalized monitoring setting. What we don't know is what the role is for medications that can influence the QT interval. Meaning, if you go online and you search QT interval and medications, you'll see lots of medications to avoid for kids that have a QT interval that's abnormal. But most of those are a prolonged QT interval, not a short QT interval. And so one of the things we're actually looking at right now are what is the relationship between medications, say flunarizine, and the QT? Does it seem to add additional risk? Are there medications that do seem to be predisposing kids to arrhythmias or not? Stay tuned. We're doing that study right now in the lab. There are devices that we can place that speed the heart up, pacemakers, and prevent the arrhythmias by shocking them. But whether these get placed in children with AHC is a very complex question. And so what I would not want is anybody to hear this talk and say, I need one of these devices just by default in my children, because we would not want that. It's a complex decision to implant any of these, and be wary of somebody who just wants to throw a device into your child. What we really highlight is, because this is a rare disease and because we're still learning about what the risk factors are and how to manage them, that we engage in what's called a shared decision-making process, meaning we trust you as parents to speak on behalf of your child and understand the best interests of your child better than we can. Our job is to work as a team to help you kind of understand what we believe right now in the year 2026. We believe the risk is of your child, how to avoid that risk, and you help us to determine what's right for you and your family. So you can imagine lots of conversation, and we want to hear your perspective. And I would be so bold as to say any physician that doesn't hear your perspective and your goals for you and your family and your child is probably not the physician that you want, say, implanting a device. Well, if all that sounds convincing to you, and you'd like to be seen at CHOP, this is the way to get in contact with us. Just let our schedulers know. Also, if you're unable to come all the way to Philadelphia, we are happy to work with local cardiologists too. We are happy to reevaluate children as best we're able. And we can do that formally or informally, depending on the logistics of the visit, and how much or how little you want us to sort of officially weigh in and to help the local cardiologist. But we fully recognize that sometimes it's just hard to travel with a child with AHC. And so the bottom line is we're here to help. Let us know how we can help you. We only want what's best for your child. And so my take-home points for our time together this evening is that the ATP1A3 D801N mutation in individuals who have that tend to have a short QT interval that can predispose them to rare but life-threatening ventricular arrhythmias. It's still possible for other AHC patients without the D801N mutation to still have a short QT. It's rare, but not zero possibility. So we recommend that everyone is evaluated. Ventricular arrhythmias in these children has been tied to periods of slow heart rate, particularly during sedation. And we find evidence of pacemaker dysfunction in many patients with AHC. We think the mechanism of this in the cell is a calcium overload state, which actually might be reversible if we are smart enough to translate what we're doing at the bench to the bedside. And at the end of the day, because of these complexities, any child with a mutation in ATP1A3 or any child with AHC should be followed by a pediatric or adult arrhythmia specialist who specializes in heritable arrhythmias. And so with that, I'll just close by saying this is our research team. They're wonderful individuals. And so these are the people who are working to actually figure out the clinical risk factors and the basic science behind the disease. I'll highlight this gentleman here in the back. This is Minu Bidzamu, who spent 5 years of his life working full-time. His entire PhD was to figure out that cellular mechanism of disease and to figure out what the D801 mutation was doing wrong in the heart. And so, kudos to him for studying this for half a decade. And I think we're smarter about the disease process because of him. And I've shared results here from lots of individuals who are pictured here. And so with that, maybe we'll open up for any questions.
It seems like Beto had to step out a minute to check on Riley, his little girl. So I'm going to, oh, there he is.
There he is.
I'm back.
Beto's back. Okay.
I'm back.
We're just to the questions, Beto.
All right, perfect. So Dr. Landstrom, and then anybody too, if anybody has any questions, feel free to put them in the chat. I'm going to start off with some of the questions that were provided to us. And I'm sure I think I heard you, I said I stepped out to check on my daughter. I think I heard you answer some of these questions, but I'll still go over them just to make sure they're touched. So I guess the first one would be big picture. Do we know if ATP1A3 mutations directly affect heart muscle or electrical signaling?
That's a very important question that has been debated about in the literature. We think we have the strongest evidence yet. We've looked at 150 kids worldwide, and that was in our previous publication. Right now, we're at about 100 patients that we've seen in clinic and about 70 other patients worldwide. So we're at almost 200 kids now. None of them have heart muscle disease. None of them have cardiomyopathy, heart muscle disease. None of them have heart failure. The echoes, as far out as we've taken them, are always normal in that the heart muscle doesn't change, the ventricles don't dilate, the heart muscle doesn't thicken, the squeeze is always normal. Now, as we all get older, of course, anything can happen. But in patients with AHC, we feel very confident that if there is something, it's an incidentaloma. I mentioned there was one kid who had a heart valve that normally has 3 parts to it, had 4 parts. The valve was otherwise perfectly normal, perfectly functional, doesn't require surgery. We've seen now 2 patients with some mild dilation of the aorta, which is the main artery that comes off the heart that brings blood to the body. That's mild. It doesn't progress. It has not required any surgery and wouldn't require even medications. That's so mild. And we have one kid with like a vein that is in the wrong place, returning to their heart. But we see that all the time in the general population. So we think we're finding are just incidental findings. We have a lot of evidence that there is no heart and muscle problem. What we think is the issue is the electricity of the heart, specifically that QT interval, specifically the electricity resetting in the heart. And we think that's generating the arrhythmias.
And then, Bill, really quick, I just got a message that their Q&A chat is disabled on their side. So I don't know if we're able to enable that so we can get some of those questions coming in. In the meantime, I'll continue with what we have over here. Is cardiac involvement under-recognized in AHC?
Absolutely. Absolutely. So if we say that the major, thing on the cardiac evaluation that we worry about is the QT interval. And the QT interval needs to be short. That's the thing that we worry about as a risk factor. What you're asking is did the individual who read that ECG know what to look for? And among all the rare diseases that we care for, short QT is among the rarest. And so many arrhythmia specialists aren't thinking short QT. They think long QT. They don't think short QT. And in addition, the machine almost always reads a short QT as normal. And even in situations where the machine has read it too short and the number is less than 350, oftentimes we're not thinking, oh, that number is too short because we're trying to think too long. So absolutely, I would say almost without exception, when we have seen kids who have had a QTC that was too short, it's been missed by at least one cardiologist prior to us. I'll also add that in the studies that we did to prove it was a short QT, we blinded ourselves, meaning we reviewed the ECGs without knowing the child's genotype. We just measured QTCs, and we had multiple electrophysiologists who specialize in kids. And we all sat down in advance and said, here's how we're going to do this. We're going to hand measure everyone's QTC. And we all agreed on the standard way to do it. And then we didn't talk to each other. We measured away. We all got close agreement independently, and we found the same thing, that the children have a short QT interval. So you have to have someone who's willing to sit down and hand measure that QT interval.
Awesome.
Somebody try to type a message in real quick if you can, not someone that's on the panelist side.
So we got a question here from Abigail. She's from Argentina, and she stated that there are very few specialists in the part of the country that she is from, Argentina. She'd like to know what specific like labs should be done for her son, so she could, send over your way.
For sure. Well, first off, it's wonderful to see everybody here, some names and faces that I recognize. So it's wonderful to see you all. I hope everyone's doing well. Really, the only thing that we absolutely positively need is that 12-lead resting ECG, that thing with all the squiggly lines. We think for completeness, it's always good to do a full cardiac evaluation. That doesn't necessarily require any blood work. That requires typically an ECG, the ultrasound of the heart. We'd like to get at least one just to make sure that we haven't picked up something else. Again, once that's normal, we check it very infrequently after that. And we always think it's a good idea to have a Holter monitor, which is that walking around heart rhythm monitor. So oftentimes it's like a big sticker that's on the front of the chest that the child wears for maybe 24 hours or a day or two. Sometimes it's a couple of leads, like 3 leads or 5 leads that go to a box that just looks at how the child's heart rate ranges over the course of a day or 2 days. And that can be very helpful as well. In terms of our ability to help remotely, it really kind of depends. So if we get all that testing and we can see the raw images, the raw data, not what the cardiologist thought, but the raw testing, and you and your local cardiologist want a sort of full consult, we can do a telehealth visit, and that allows us then to be a bit more involved. Or we can do a quick, like we call it informal, just check-in, a curbside. That we need to do if for example, the testing has been limited, we don't have a lot of data on your child, we can kind of weigh in, but then we can't weigh in as fully as we might otherwise. And so all of our recommendations would have to kind of be with a grain of salt. But if we can get a good comprehensive evaluation, see you formally over telehealth, we can weigh in.
Beto, just tell them to use the question and answer box. Should be able to put questions right in there. It's down the bottom under the more feature. There's a Q&A.
Yeah,
okay.
Yeah, I look, that's where we're getting some of the my questions there as well. And I think Christine Simmons probably raised her hands. I don't know if you still have a question that you wanted to say out loud or no.
Can you hear?
I see Karen Benty.
Yeah, is it me that you're talking about?
Yeah, go ahead, Karen.
I can't see myself on this Zoom, so I can't tell if I'm muted or not. So I'm assuming I'm not now. Hi, Dr. Landstrom. Thank you so much for the research you're doing. This is popping up as something that's, I think, going to be important for my daughter. So I was, she's 26. We've had our every 3 year echoes, our routine cardiograms.
Yeah.
She had like mild tricuspid insufficiency, but everything was like,
Mhm.
nobody ever like was worried.
Yep.
And then I saw her variant, which she's the only one with her variant, show up in a paper. I think it was one of the repolarizations or depolarizations paper as having short QTC, which I didn't know about. And then we went to a cardiologist. And I think at first I asked him, we're really here to find out about this QTC thing that they're talking about. And I said, what does hers look like? And he said it was normal. And then he came back and said, no, it's short. But he said just what you said, and what I find in every ER visit, everybody says, oh, we only worry about long QTCs, not short QTCs. And I, I think I'm under the impression as well is that the QTC can change in and out of that short status, because I think hers does. Like, of course, I don't know if they're calculating it the way you're talking about. But I guess like in life, I always thought it was going to be safer for Addie to go under a conscious sedation or a general sedation for things like dental work. She had a lip biopsy, and then of course she's in the ER a lot, and we are always trying to make that decision between 10 hours of stridor and do we finally intubate because she's just physically exhausted or not. And now I'm wondering if we're really not as safe as we thought we were once we went under anesthesia. And she seemed to have a really bad reaction to Precedex. She ended up in a 1 month ICU stay when usually it's 4 days. We're in and out 4 or 5 days.
Precedex is the other name for that dexmedetomidine.
Yeah.
Well, so a lot to unpack there. Thank you, Karen.
Sorry.
So this is great. I think your story is really quite common. So what probably happened was they just sort of took a quick glance and like, oh, it's not long, and the number doesn't look long, and so it looks normal, but he or she probably went back and hand measured it and saw it was short, and that's what we've seen a lot. And now it's important to recognize a couple of things. So just like you said, the QTC in most children doesn't really change much over time. It can prolong a little bit during in biological females when they hit childbearing years because estrogen prolongs it a little bit. Sometimes salt imbalance in the blood or dehydration can prolong it a little bit. But generally, what we have found with AHC and ATP183 and D-to-1N specifically is that if it's short, it tends to stay short. But remember, I talked about that graph with the tilted line. Kids with D-to-1N, that QTC, which is supposed to remain stable, remain constant, actually changes and is dynamic. And the slower the heart rate, the more it'll shorten. If, for example, they happen to catch it when the child's heart rate was fast, it can actually mask the short QT. So I totally expect one reason to be, well, perhaps the heart was a little bit variable, and normally that gets factored out and it doesn't affect the QTC, but not in kids with D-to-1N, it does. Going back to the question of anesthesia, so kids with if we say, okay, who are the kids with just short QT without AHC? This very, very rare kid, and they have mutations in other genes. They can have arrhythmias at home. We have found is that, for example, many kids that we have had these scary events from, they're not having them necessarily at home. So there's something about the medications that we're giving to them that is making them more risky than they are when they're not getting those medications. And we think those medications are slowing the heart, and we think we've pegged it to anesthetics or heart rate slowing medications. But it's important that not all anesthetics are the same. And even if there is a risk, so say it's dexmedetomidine, Precedex, there are situations where you need to sedate that child right now, and Precedex is what you got. And the benefit of sedating that child far exceeds that risk even of Precedex in a D-to-1N short QT child. So I would hate for anybody to say, like, my child should never be sedated for anything after this, because That's where we talked about kind of risk and benefit. There is that risk, but there are times where that risk is justified. So what we've generally said is if it's an emergent situation and that child needs to be intubated, like the child who's got stridor, who's looking really tired, that child needs to be intubated. And in that setting, that anesthesiologist needs all the tools at their disposal to safely intubate your child. If you can say, oh, I'll stay away from DEX, let's go with something different, that's fine. But the priority in that scenario needs to be the safe intubation of your child. If it's, you know what, next Tuesday, we're going to do a brain MRI. Next Wednesday, we're going to sedate your child for, you mentioned a dental procedure. One, you need that MRI. Two, you need that dental procedure. Like they would not be saying that if your child did not need those things. So there's a benefit to having those procedures. They're elective, so you have time to talk about it. That's when the conversation about, well, let's make sure they're in the hospital. Let's make sure their heart rate is monitored. Let's make sure the anesthesiologist knows to avoid slow heart rates and avoid medications that are predisposing to slow heart rates, as long as you can have that conversation with them. And every anesthesiologist worth their salt can in that non-emergent situation can flex with you and make a plan that's customized to your child. In addition, every anesthesiologist worth their salt has medications in their pockets to increase the heart rate very quickly. And shifting the conversation a little bit to say that your child's a little bit different than other cardiac kids. Other cardiac kids, you want their heart slow, 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 slow. Your children with the D801N who are high risk, err on the side of fast. So I'd much rather their heart rate be 120 for a few minutes than 40 for a few minutes. And so we would err on the side of avoiding bradycardia, avoiding those heart rate slowing medications. And if you see bradycardia, go ahead and give something to speed the heart back up. Those are the recommendations we make to anesthesia.
Great, thank you. I have had many an anesthesiologist who asks, what should we be using? I'm like, I don't know. I have no idea. So this, will eventually be really
absolutely
useful information. Yeah.
We are in the process of working with folks like the AHC Foundation and on the scientific side to put together sort of straightforward guidance documents that summarizes all of this.
Yeah.
And to say, like, this is the care that we recommend based on this data, as opposed to just sort of hearsay or anecdotal evidence. I think we have pretty good data for all this.
Yeah, that'd be terrific. Thank you.
Of course.
All right, I know we have quite a lot of questions actually. So we'll probably just hit on a couple more and then email them to Dr. Landstrom and get more answers from you on some of these. So another one, are there specific red flags families should watch for at home?
Things we always want to know about, not just for kids with AHC or ATP1A variants, are changes that might suggest that the heart is doing something that we want to know about. The big thing for us is fainting. And so typically, when we first meet you for the first time, we want to know, what do their AHC spells look like? Because you know really well what those spells look like, and you can tell us, gosh, you know what? This was different. They just collapsed. And normally, they don't just do that. And so if you've noticed that, we typically want to know. Generally, we say anything that's out of the norm for their AHC spells or the seizure-like activity they typically have, we want to know about that. Doesn't necessarily mean we're going to rush out and do 10,000 things, but we want to know. At the end of the day, maternal and paternal intuition reigns supreme. So if you're worried, I'm worried. And what we typically want to do in those scenarios is get a bit more information to know what we're dealing with. And so that's where those heart rhythm monitors really are important. We can typically mail one out to the family, or they can get one applied by their local cardiologist. In some kids, they're high risk and we're really quite worried, and the parents are worried, and we'll actually implant a little heart rhythm monitor under the skin. Those are called implantable loop recorders. And all it does is it looks to see if the heart rhythm is always normal, if the heart rates are always normal. And the nice thing about having one of these in place is that if you see one of these concerning symptoms, you don't really have to know what you're concerned about. You just press a button and you say, they're looking dusky, they're tired, they collapsed, they just had an AHC episode. Anything that you want us to look at, we can correlate with the heart rhythm during that time. And that can be a really powerful tool, because if we say, hey, look, they had 5 AHC spells. They had 2 episodes of that weird unresponsiveness and 1 episode where they were just crabby and fussy. And all of them were normal heart rhythm and all of them were normal heart rates. That's very important objective information where you as a parent can go, okay, but we've got evidence that that was just, it wasn't the heart that was causing those symptoms. Conversely, every now and then it is the heart. And then we have all the evidence we need to actually act upon whatever we saw on that monitor. Hope that helps.
Thank you. And then I'll actually, again, we've got quite a few questions, so we'll definitely send them out to Dr. Landstrom and try to get them answers to you guys and send them via email. But I don't know if Brenda, I don't know if you put this in the Q&A, but I don't know if you want to share it with Dr. Landstrom yourself. I feel like it's more of a message that you should probably, that would be very appreciative to that Dr. Landstrom. I don't know if you want to go for it. Let me see if I can, Bill, can we unmute Brenda? Oh, go ahead, Brenda.
She should be unmuted, Brenda.
Okay, let's see if this is not muted on my end. I'll just go ahead and read what Brenda said, Dr. Landstrom. She said, in Australia, we have not been able to find a cardiologist that has experience with AHC or short QT. Short QT was found at Joel's last exam, and the cardiologist was not aware of what to do. I reached out to Dr. Landstrom, who provided guidance and support. I wanted to thank Dr. Landstrom, as I truly appreciate that support, as we often feel isolated and dismissed in terms of specialists, particularly as we have moved from pediatrics to adults. So I think a lot of families here share that same sentiment. We all really appreciate the work that you have done in pediatrics, and so many families are very appreciative and thankful for all the work that you have done. And same thing with Teralyn. But thank you for everything that you've done. And with that being said, I'll see if you want to have some last few words, or if Vicky wants to chime in here.
I will chime in and thank everyone for joining us tonight, especially Teralyn and Dr. Landstrom. I want to just add personally, Dr. Landstrom has trained Emma's adult cardiologist, so he is spreading the news throughout the country, and we are slowly working with adult physicians as well. So please continue your work in our community, because we are very appreciative of everything you're doing. And we want to thank you for joining us tonight and extending your work day to help out some parents. So thank you so much. If you want to add any wrap-up points.
Just to say thank you all. We get a sense of what you all go through, but really, I mean, we can't even begin to comprehend what you guys go through. And there's a diagnostic odyssey of trying to figure out what's wrong with your child. Then there's the uncertainty when you have a diagnosis of what to do about it. And so what you do is inspiring to us. The reason we're here is to help families like yours. Know that you're not alone. And whether it's Australia or Chicago, we are always happy to help in any way that we can. Thank you all for doing what you do and for allowing us to work with you. I'll add that the work that we do, we couldn't do if you all didn't give us permission to learn from your children. Every single last patient, that we study has signed a consent form that said, yes, we can do this. And that takes time. And you've traveled with your child, you're tired, your child's tired. It's been a big day in clinic. And then to say, we're going to sign a consent form to let you learn is just, it's very humbling in the midst of everything that you all do. So thank you. It's a real pleasure.
Thank you.
Thanks,
Appreciate
Dr.
everyone
Landstrom.
coming.
Thank you, Teralyn.
It was in Teralyn. It was very informative. Thank you so much.
Thank you so much for having me.
Yeah,
Have a
it
good
was
night,
great.
everyone.
Have a good night.
Thank you,
Thank you so
everyone.
much.
Take care.
Good night.
Thank you all.
Thank you.
Okay, thank you. Bye bye.